Hi everyone, welcome to ResearchMD.com. My name is Pramil Cheriyath. I'm a program director in internal medicine residency, transitional residency. I'm also a director of research, assistant professor of medicine in two large medical schools in the United States. We have been doing a series of lectures on anemia. We did anemia, microcytic anemia first, and then macrocytic anemia, and then we've been going to hemolytic anemia. So today we have a great topic, and topic is sickle cell anemia. Okay, a lot of information we need to cover. We're going to go a little bit fast. Thank you for watching today. Okay, so let's talk about our definition. What is the definition, or like what happens in sickle cell anemia? Okay, it's a mutation, right? Mutation in the globin chain, beta globin chain. Okay, so 17 right here. That's what 17, the nucleotide. Okay, that's converted like thymine. Instead of thymine, it can convert it into adenine. Very important. Okay, and then next is the 6th amino acid. Okay, what happens over here? Glutamic acid converted into valine. So we need to know that. What that results in? Hemoglobin polymerization. Okay, so let's go back again. 17, the new mutation in the beta chain. What is that rated? 17, somebody tell me.
On the 17th nucleotide, there will be thymine
is replaced by adenine. Okay, on the 6th amino acid,
glutamic acid
replaced by valine, which results in hemoglobin polymerization. Okay, so let's look at like epidemiology a little bit. African Americans or African descent people at high risk, and especially also the people where the malaria is predominant. Also, these people at high risk of sickle cell disease, and then it also protects. It's good to know, like, but against Plasmodium falciparum. Sometimes examination question can cover that also. Okay. Now, when you classify sickle cell disease, there's three main types. There is like HBSS disease, so you got two copies inherited there. Okay, and then this is where the severe form of disease, and then you got hemoglobin S, beta thalassemia. Somewhere in the middle, you can still have hemolysis and all that, not as severe as the first one, HBSS disease. Now you have sickle cell trait, only like one copy is like inherited. Mainly, these patients remain asymptomatic. Okay, no problem. They will not have any problem at all. It's one of those lab findings. But what's important is it can sometimes present it with gross hematuria because of the papillary necrosis. Remember that. Sometimes an examination question will be just asking this painless gross hematuria in sickle cell trait patient due to the papillary necrosis. Okay, remember that. Now, clinical presentation, severe pain, right? Your vaso-occlusion, all this sickling, get like obstructed the vessels. So you can have severe pain, hand and feet, you can have dactylitis, right? And the next one, you got the hemolytic anemia. Only when the patient is symptomatic or patient going through crisis, that's where the symptoms kind of, hemolysis actually happens. So everybody knows the hemolytic anemia, you can have pallor, jaundice, splenomegaly, gallstone, those kind of picture and all that, right? And then we talk about the vaso-occlusive crisis, all this blood vessel occluded with all this sickle cells and causing like blood supply problem, severe pain, bone joint. When you talk about the bone, always remember this. A vascular necrosis of the femoral head. Also, that's very important. Okay, sometimes they come up with the pain in the hip. That's also an emergency. Lung, kidney, brain, and all of these places you can have like infarction. You can have acute chest syndrome, which is another deadly complication of sickle cell disease, which will come back and later. You can also have a sequestration crisis, massive entrapment of sickle cells, so rapid enlargement of the spleen, and that patient can go into shock. Okay, and then a plastic crisis. I mean, mainly we have to think about the parvovirus infection. It's also very significant. And then if you look at stroke, like 20% of this patients, sickle cell, can have like stroke, like a brain MRI finding have something to do with stroke, okay? So it's very important, like some of them may remain like asymptomatic, but they have like cognitive disabilities because of that, okay? So it's very important. Also priapism, also very common in this patient, and cerebral aneurysm, there are reports of like brain bleeding in this patient, okay? So all of this kind of thing of, and then also you need to understand you can have like a frequent splenic infarction, and then you can have like autosplenectomy. Remember that, okay? And then when you have autosplenectomy, like what happens? You can have infections, right? And the spleen is gone, especially in encapsulated organism. We're talking about Streptococcus pneumonia and H. influenza, okay? Now we talked about this side, and the most important side is over here. We're going to talk about, the pathophysiology, what happens over here, okay? So what happens over here is like you got the oxygenated form of hemoglobin. As in that situation, everything calm, nothing happened. Okay, but what happens is you got some triggers. Okay, so what kind of triggers kind of turn this around? Let's say dehydration, right? Dehydration, hypoxia, infection, okay? Acidosis. All of these triggers, what happens? You got deoxygenated erythrocytic HBS happening, deoxygenation happen. Then the hemoglobin polymerization start. When you talk about hemoglobin S, it's like hydrophobic moiety also. So hemoglobin polymerization happen. Then what are you going to have? Like the sickle cells, right? Sickling. Sickling, what happened? What is the sickling is going to do? That can cause hemolysis, right? You can cause infarction, right? And what happened is like occlusion of the post-capillary venules, and then after that you can have like free radical formation, and then you can have reperfusion. What happens when you reperfusion? Oxygen-free radicals form, and more damage to the tissues happening and all that. When you talk about infarction, we already talked about the splenic infarction, right? Autosplenectomy and all that. Infarction can also cause like acute chest syndrome is very, very important, okay? When you talk about the acute chest syndrome, most of these patients with the sickle cell disease usually die because we don't know how to recognize the acute chest syndrome. So it's very important to know what is acute chest syndrome, okay? So we know the sickling crisis cause infarction. So how do you diagnose acute chest syndrome? Most of the clinicians usually miss it and end up patient dying, okay? So what is the definition? You should have a new infiltrate on chest x-ray and one of the following. Okay, one is like temperature greater than 38.5 degrees centigrade. Greater than 3% decrease in saturation, okay? That's very important. It's not about saturation. They don't have to be hypoxic. That's why you need to measure these people's baseline saturation. Let's say a sickle cell patient, baseline saturation is like 97%. If it drop like 3%, that's also a bad sign, okay? Remember that. Don't assume, we always say like, oh, it's not hypoxic. So it's very important. Some of these places, they give a pulse oximeter to the sickle cell patient, so they can monitor the saturation, okay? And then you can have tachypnea, intercostal retraction, nasal flaring, and accessory muscle use. And then you got chest pain, cough, wheezing, and rales, all of the symptoms. So again, new infiltrator on the chest x-ray, plus any one of this finding, okay, that can cause the acute chest syndrome. And how do you treat acute chest syndrome? You have to give exchange transfusion, okay? What is the word we have to use it again? So let's go back up here, and again, so we talk about this infarction, there's VCAM and hypercoagulability, and also one thing we need to understand, when the hemolysis happens, okay, what happens is like the hemoglobin breakdown, there's free plasma hemoglobin inactivating the nitric oxide, okay? Nitric oxide needs vasodilation, so many things in the body, so there's like decreased nitric oxide production. That's one of the basic pathophysiology behind it. Also, what happens when the hemolysis happen, increase arginase 1, which you convert arginine into ornithine. Okay, you need arginine for the production of nitric oxide. So in this case, because of increased arginase, more arginase you convert it into ornithine. It's also bad because there's going to be less nitric oxide production. It's very, very important to know that. Okay. So you already talked about the free radical damage. And pulmonary hypertension is also another complication because of this infarction. And then, I think they are trying, you can do endothelial antagonist for treatment. Viagra also has a role in the treatment for that. Okay, now, we did all this thing, now we have to come up with the investigation. What do we find? The hemoglobin is going to be low. It decreases hematocrit. Most common finding, usually, MCV is going to be normal, but the hemolytic picture only when this crisis or triggers happens, okay? That's when you see all this hemolysis, reticulocyte count, you got unconjugated bilirubin, increased LDH and haptoglobin only during that period. So, and then you can always do the hemoglobin electrophoresis test. That's the first thing you have to do, right? So what happens? You got a cathode and anode, you pass electricity. Now let's look at the normal adult. You got two called AA, right? And then you got, in the newborn, you got AF combination right here. And what happened is like the sickle cell trait, which is asymptomatic, you can have like AS and then two S's over here for sickle cell disease, which is the one like very, very deadly or can cause all this pain and all this crisis and all this thing we talk about. Okay, so now let's look at the peripheral smear. What will be the classic finding in the peripheral smear? Of course, the sickling, right? Sickling shape, and then you can see in the peripheral smear. You can also have Howell-Jolly body, which is actually reticulocyte have remnants of the nucleus, and that's what is actually Howell-Jolly body. You can also paint like target cells. Now, how do you diagnose this in the babies? Usually start in the neonatal period. You can do prenatal testing, chorionic villi sampling, DNA sampling at 8 to 12 weeks of gestation, and you can come with a diagnosis, okay? Now, how do you treat it? There are, some treatments available, hydroxycarbamide or hydroxyurea, and what does it do? It increases the HbF production in the body. So usually acute chest syndrome is very less in these people. Stroke is less, pulmonary complication is less. So it's a good idea to start like a prophylactic treatment. It also, again, it's anti-inflammatory and it also decreases leukocyte production. Hydroxyurea we usually use to treat like thrombocytosis also. Okay. Now, when we talk about, and then stem cell transplantation is available with the stem cell gene transfer, but you need HLA comparable family member to have that transfusion. So if you can do that, that is probably more only the curative treatment available. And then again, we talked about acute chest syndrome. Most deadly, most physicians and the clinicians miss it. Patient end up dying because the treatment is what? An exchange transfusion, not the regular transfusion. Remember, you have to do exchange transfusion. Always, you start the patient on broad spectrum antibiotics, you give oxygen, you give IV fluids, and also you give nebulizer treatment, okay? Remember. And then we talk about avascular necrosis of the femoral head. The patient usually kind of comes in with the hip pain. If you ignore that, what's going to happen? Collapse of the femoral head, right? That another major complication. So anytime this patient come with the joint pain, that's another examination or a board question. If I'm writing a question, remember that. So how do you treat that? Core decompression and bone marrow grafting is the recommended treatment for that. Okay, then you got priapism. You can give adrenergic agonist, phosphodiesterase 5 inhibitor. Finasteride can also be used to treat priapism. And for transfusion, your goal is to make sure hemoglobin stays between maybe 8 to 10. Your goal is to make sure HbS comes below 30%, especially if they're going before surgery and all of that, like very, very important, okay? And again, when it's infection, like what are the two organisms I said? Somebody tell me, what are the organs? One is Streptococcus pneumonia, other one is H. influenza. Encapsulated organism, most of these people, usually they have spleen in the childhood, but as they go into adulthood, that is the autosplenectomy happen. Make sure you give broad spectrum antibiotic, and you also make sure you cover with the vaccination for this against encapsulated organism is very important. Okay, so if you miss, if you can remember one thing, always remember about acute chest syndrome. Sickle cells in patient with the sickle cell crisis or sickle cell disease can have acute chest syndrome. That is the deadliest complication you can easily miss. So just summarize again, like really fast. Okay, let's talk about the 17th nucleotide. Right? What happens is thymine is kind of converted into adenine, and the 6th amino acid, glutamic acid, converted into valine. There's like polymerization going on, and then we talk about the plasmodium falciparum protection in the endemic areas. We talk about the sickle cell trait is the one like, and it can cause like painless close hematuria. That can be another examination question right here. And then you have all of this complications starting with hemolytic anemia, vaso-occlusive crisis, acute chest syndrome, and then you got sequestration crisis with rapid enlargement of spleen and shock, and patient could die, and then stroke, you got paraphism, cerebral aneurysm, bleeding, okay, autosplenectomy, all of that. And then we come up here looking at the pathophysiology. What happened, HBS in the oxygenated form, it's okay. But anytime there's a trigger like infection, there's dehydration or any kind of acidosis, all of this kind of, and hypoxia, because the deoxygenated erythrocyte become polymerized. Right, hemoglobin polymerization, sickling happens, all this obstruction, there is post-capillary venous occlusion, and then what happened, there's reperfusion injury, oxygen-free radical. Remember the role of nitric oxide. What happened nitric oxide again? You have nitric oxide is going to go down, but nitric oxide is very important for the body to function, right? And so you got hemolysis, there's hemoglobin release that kind of decrease nitric oxide. Also you can increase arginase 1, which convert arginine to ornithine. You need arginine for nitric oxide, but this is all arginine is kind of already converted into ornithine, okay? Then you talk about all this infarction, acute pain, acute chest syndrome, hyposplenism, osteonecrosis, and there's inflammation, hypercoagulability, pulmonary hypertension, paraphism, leg ulcers, which is, like a very common in all hemolytic anemia. And then cerebrovascular disease, don't forget, 20% of these people have stroke, and they might not even know. They can have cognitive disabilities. And then we talk about again, acute chest syndrome, new infiltrate on chest x-ray, plus any of this following, like increased temperature, increased work of breathing, hypoxia, from baseline 3% drop, and then intercostal retraction, chest pain, cough, wheezing, any of these rails, be careful, treat as like acute chest syndrome. Then we talk about the hemoglobin electrophoresis, Havel-Jolly bodies, right, target cell, and then you got sickle cell, right? The classic picture, prenatal testing and role of hydroxycarbamide, hydroxyurea, and how to treat acute chest syndrome, right? Make sure you give IV antibiotics right away. Exchange transfusion is the word, my friends, okay? And then keep the hemoglobin between 8 to 10. Make sure hemoglobin S is like less than 30%. Make sure also you vaccinate, treat paraphism, and don't forget a vascular necrosis of the femur head, okay? Thank you so much for watching. If you have any questions, please put it under comments. We'll be back with another presentation soon. If you could subscribe to our channel, greatly appreciate it. Again, it takes a lot of people's effort to make presentations like this. Thank you so much again.